Hope you can hear me well. Can see we are now 26 or 27. Very good, Mohammed. So this morning I sent some structures, non-steroidal anti-inflammatories. Please print them, and that's what we are going to discuss. Actually, everything that I have sent to you, I believe by the time we are through with the non-steroidal anti-inflammatories, we'll be able to discuss. I've also sent some structures for the prostaglandins. Again, check your email. Kindly print them, look at them. If there's anything you don't understand, kindly ask. I will send also other structures for the commercial prostaglandins that I didn't check, I didn't send. Is a bit we did not discuss on the prostaglandins nomenclature, and I think SAR. Again, we will revert back to that. But there's no problem. Let us start on the non-steroidal anti-inflammatories, because also of time, there is an issue of time. I'm sorry, I was supposed to meet you on, I was supposed to have a class on Wednesday. I got a bit held up, but I think from next week we can try and have 2 classes so that we see whether we can finish as early as possible. This morning, I want us to look at the non-steroidal anti-inflammatories. We started with the prostaglandins, and we did mention that the precursor of the prostaglandins is arachidonic acid, an acid that is not preformed, is not stored in the. The prostaglandins, are not stored in the body. The arachidonic acid is stored as a phospholipid, and of course, when you need it, when you have stress and injury, stimuli, then it is released from where it is esterified from, esterified, that is from the membranes, through the cleavage by phospholipase A2. Phospholipase A2 being the most potent, or being the most active of the phospholipases. So once it is cleaved, we also did mention it's also known as eicosapentaenoic tetraenoic acid. It has 4 bonds. It's a straight chain free fatty acid. Once it is released, it is acted on by cyclooxygenase enzyme. There is cyclization for us to get the cyclopentane ring. There is oxygenation at position number 15 for us to be able to get now the prostaglandin G2, then converted to prostaglandin H2, and then from prostaglandin H2, you get all the prostaglandins. Those glandins, they have several functions, as we discussed last time. They have cytoprotection. They do they protect the GIT. They do protect the kidneys. They are responsible for homeostasis. They regulate also clotting through control of platelet aggregation, vasoconstriction, and vasodilatation. At the same time, prostaglandins are responsible, and that is now where we're going. They're responsible for pain, fever, and inflammation. So it is important for us to understand that is a link. That is why we start with the prostaglandins. We understand them, and we know they do have some homeostatic effects, but they do also have some negative effects in the body. They are responsible for pain, inflammation, and fever. So when you do have an inflammatory reaction, or when you have an injury, an inflammation will kick so that you protect the tissues. But the minute also that inflammatory process kicks off, also you need to stop it, because excessive of the inflammatory process will also cause tissue damage. So once the prostaglandins are formed, they will cause pain, fever, and inflammation. And indeed, that is the basis of the action of the non-steroidal anti-inflammatories. The non-steroidal anti-inflammatories are supposed to block the synthesis of the prostaglandins, specific prostaglandins, synthesis of prostaglandins when there is injury, when there is a trauma, blockage when there is pain, blockage of the synthesis of the prostaglandins. So how does that work? How would that work? That would only work if the non-steroidal anti-inflammatories are able to block the enzyme that converts arachidonic acid to prostaglandins. And indeed, the mode of action of the non-steroidal anti-inflammatories, whether selective or non-selective, of course, we come to the specific, is blocking that enzyme that is responsible for conversion of arachidonic acid to the prostaglandins. That enzyme is the cyclooxygenase enzyme. So the mode of action of the non-steroidal anti-inflammatories is to block the synthesis or the cyclooxygenase enzyme, and in blocking the cyclooxygenase enzyme, hence block the continuous or the continued synthesis of the prostaglandins, and hence block pain, block fever, and block inflammation. Now, when we were discussing, or just now I have mentioned that we do have important prostaglandins. So that means, therefore, if you block the cyclooxygenase enzyme, you would expect to have toxicity. The GIT protection, the cytoprotection will be blocked. The platelet aggregation, there will be issues with clotting. There will be issues also with the kidney function, because you have blocked these prostaglandins that are responsible for that homeostatic process of the body. So when we look at the cyclooxygenase enzymes in the body, we find out that we have two types of cyclooxygenase enzyme. We have COX-1 and you have COX-2. COX-1 and COX-2. When you look at COX-1, we do have COX-1 is usually what we call constitutive. Constitutive means all of us have the COX-1 all the time in our body. Then you have COX-2 enzyme, and COX-2 has two portions. COX-2 has one which is constitutive, which is also found within the body, but also it has COX-2 which is inducible. When you talk about inducible, what we are saying is that when you get the injury, when you get the inflammation induces formation of COX-2. Once it induces formation of COX-2, that induced COX-2 is the one that is responsible for synthesis of the extra prostaglandins that cause pain, fever, and inflammation. So therefore, the COX-2, which is constitutive, and the COX-1, which is constitutive, need to remain in the body, for the body function to be optimal. So, and that is again tells us the need for selective non-steroidal anti-inflammatories. You want non-steroidal anti-inflammatories really which go for COX-1. They will go for both COX-2s, but they will spare COX-1 and go for COX-2. So they will go for constitutive COX-2 and also go for constitutive COX-1. So you need non-steroidal anti-inflammatories which spare COX-1 constitutive, but go for inducible COX-2. But at the same time, of course, they will go for constitutive COX-2 because the structures are basically the same. Once you get such a non-steroidal anti-inflammatory, then you will have minimal toxicity. But as we have always learned about drugs, normally it is a continuous development. So the first class of non-steroidal anti-inflammatories are the non-selective. The non-selective means they go for constitutive COX-1, they go for constitutive COX-2, they go for inducible COX-2. And therefore, once they block the constitutive COX-1, which each and every one of us needs for the proper optimal body function, you will have a lot of toxicity. And that is why some of the drugs, aspirin, indomethacin, diclofenac, these are non-selective. They go for all the COX enzymes and therefore bring a lot of toxicity. So when we look at these drugs, the non-steroidal anti-inflammatories, let us be reminded that we are coming from the prostaglandin and we are developing a molecule that should go for the same site. It should go for the same site as arachidonic acid on the COX enzyme. So the molecule which we are calling the non-steroidal anti-inflammatory should have competitive inhibition, should inhibit arachidonic acid from binding the COX enzyme. So what does that tell us? Our drug, the non-steroidal anti-inflammatory, must have some structural resemblance, must have some structural resemblance with arachidonic acid, so that it can go for the same site on the COX enzyme and block arachidonic acid from binding, and hence block a conversion of arachidonic acid into the prostaglandin. So that is just an introduction. And of course, for us to understand what is the connection between the non-steroidal anti-inflammatories and the prostaglandin, both of them, the non-steroidal is going for the COX enzyme, but it's going for the COX enzyme to block it. It goes and sits at the site where arachidonic acid sits competitively, and therefore arachidonic acid is not being converted into the prostaglandins. But as we have said, for it to have very good effect, it should go for selectively for COX-2 inducible, but that does not happen always. So that is the introduction and the connection between the COX, the prostaglandins and the non-steroidal anti-inflammatory. Of course, non-steroidal, just from the name, we have two classes of anti-inflammatories. We have the steroidal anti-inflammatories, the steroidal, they just have the steroidal structure. After this, you can check up the steroidal structure. It is a structure which has about 4 rings, all fused together. Steroidal, like dexamethasone, hydrocortisone, betamethasone, those are steroidal. And those ones act a little bit higher. They block the phospholipase A2. And that is why they have very, very severe toxicity. So the steroidal anti-inflammatories work a little bit higher than the non-steroidal anti-inflammatories, block the whole of the phospholipase. It does not convert. It does not release the arachidonic acid from the phospholipids. So introduction, inflammation. We have 4 signs of inflammation, and of course, all of us know this. You do this, more of this in pharmacology. You can get redness, and this is due to the local vasodilatation. You will get heat due to the local vessel, again, dilatation. There will be swelling due to influx of plasma proteins and phagocytic cells into the tissue spaces, and there will be pain due to local release of enzymes and increased tissue pressure. So all these things will happen when you have an inflammation: redness, heat, swelling, pain. Remember, the inflammation, when controlled, it is important because it protects tissue injury. But to the excess, it becomes a problem. Again, it will cause tissue damage. So those are the 4 signs of an inflammation. What is the importance of the non-steroidal anti-inflammatories? They cause relief of pain, and therefore they have analgesic activity. They suppress the signs and symptoms of inflammation. That's why we call them anti-inflammatories. They exert antipyretic pain, they lower the fever, and that is why we call them antipyretic. So most of these non-steroidal anti-inflammatories have analgesic, antipyretic, and anti-inflammatory activity. The one we are majoring on is anti-inflammatory activity, but most they are given, they will also have the other effects. And they are useful in pain related to inflammation, especially for superficial and integumental pain. Now we want to look at the classes. How many classes? We have about 6 of them. Classes of the non-steroidal anti-inflammatories, and we have mainly 6 structure-related groups. Some of them not really related, others closely related. We have the carboxylic acids, and the carboxylic acids are also the ones known as salicylates. Carboxylic acids, let me make it bigger. Carboxylic acids, also known as the salicylates. This is where you get aspirin. We get one of the very simple drugs that we call aspirin. It's a carboxylic acid. We're just calling them carboxylic acids. They have a carboxylic group. But even all the others, you will note, they all have carboxylic acid. It is just a way of classification. So carboxylic acid. But why we are calling them carboxylic acids is that the major difference between the carboxylic acids and the others is that the carboxylic acid, for the carboxylic acids, the carboxylic group, with the exception of phenamic acid, is directly attached to the phenyl ring. This you will see. So we have also, they're also known as salicylates. Then you have acetic acid. We all know acetic acid is CH3COH. Acetic acid has is CH3COH. It has 2 carbon. It has 2 carbon atoms. That's acetic acid, CH3COH, and that means Now, these drugs, the carboxylic acid is not directly attached to the let's call it ring A, because you're going to look at the structure, to ring A, which is usually hydrophobic ring, but they are attached through another carbon. So there is a carbon between the carboxylic group and, let's say, the ring A. And we also call them aryl and heteroaryl acetic acids. When we say aryl, it means the acetic acid is directly attached to an aromatic ring, a phenyl ring. Directly attached to a phenyl ring, that is the aryl. Heteroaryl means that the acetic acid is directly attached to a heterocyclic ring. That's the only difference. So that is an aryl, and that's a heterocyclic ring, and attached to where the the acetic acid is attached. So this aryl acetic acid is just a more deeper, where it is telling us where the acetic acid has been attached. They are attached to a phenyl ring, heteroaryl attached. Aryl meaning aromatic, heteroaryl meaning it's attached to an aromatic ring, which also has a heteroatom. Then we have the propionic acid. This propionic acid, we see here, we have said we have a carbon which is separating the carboxylic group and the ring A. Here we will find in propionic acid that carbon, the carbon we are talking about, which is separating, has been branched. Acid has a carboxylic group and a hydroxyl group. So the hydroxyl group in salicylic acid is replaced by an amino group. An amino group is NH2. So once you replace the hydroxyl group in salicylic acid with an amino group, you get anthranylic acid, and that's why we are calling them anthranilic. So they are derivatives of anthranylic. Again, we're going to look at them in details. Then we have the non-acidic compounds. Under the non-acidic compounds, there is one drug we call nabumetone. Nabumetone is indeed a prodrug. It is not, it is supposed to be under the profens, but nabumetone is a prodrug. It is acted in the body to form carboxylic acid or to activate it. Then we have the coxibs. The coxibs are the selective. Coxibs are the selective non-steroidal. And then you have the anilides. The anilides is where paracetamol is. And most of the anilides are not anti-inflammatories, although we put them here. They are not, they are mainly for fever and pain. They really do not have a lot of inflammation. They don't bring a lot of inflammation, but we put them under this class because they just have analgesic and also antipyretic activity. I've said nabumetan is a prodrug. We're going to look at it, and then we have the coxib. Coxib are actually some of the most recent. These are the selective non-steroidal anti-inflammatory, where we have rofecoxib, celecoxib, and so on. We're going to look at them, all of them in details. So by the time we are done, we will have known all these drugs. Again, honors is on your side. You have to start singing them as a song. Make sure you don't confuse one with another, because by the time you are done, we'll have started many drugs. You have to start reading, and as you continue reading, they'll stick in the head. So we start with the first class, carboxylic acids. And what I want us to do, I don't know, were you able to print? I don't know whether you were able. I sent it too late. Were you able to print the structures I sent to you? Had I requested you to draw the structures of the non-steroid? I can't remember. Naomi, the students, were you able to print the non-steroidal anti-inflammatories which I sent to you?
No.
You are not able. Are you able to check them on your phone as we discuss? Are you using your laptops to log in, or your phones? Hello?
Phones.
You are logging in with your phones, eh?
Yes.
So there is no way you can be able to see the structures, eh?
Yes.
Okay, no problem. We will still survive. We find a way. So we are looking at the first category. The first category is what we have called the carboxylic acids or the salicylates. Most of them are indeed salicylates. And in that particular class, we have two categories: the acetylated. Acetylated means they have an acetyl group. Acetylated means they have an acetyl group, and the non-acetylated, we have the aspirin, and then we have the non-acetylated. They do not have an acetyl group. You have choline, magnesium, salicylate, diflunisal, and this. You will check. I've sent you this. Even if I have not sent you this, I will send it to you. Diflunisal. So these are the classes. You have salicylamide, salicylate, sodium salicylate. We will look at all of them and understand the differences. Then we have the non-steroidal acetic acid derivatives. Acetic acid derivatives. And when we look at, I've done this twice. Oh yeah, let us look at this one here. The acetic acid derivatives. Again, remember I have said, when you talk about the acetic acid derivatives, as we are saying they are separated with the carbon. I think the best is that I get you and I show you, so that we are not just talking, we're not seeing what we are talking about. Yes. So these are the salicylates. These are the examples. We are looking at the examples of the carboxylic acids or the salicylates. You can see the first one is the acetyl. This is acetyl. You can see this group here. CH3 C double bond O, acetyl, CH3 C double bond O. That group is the acetyl. Remember, salicylic acid is a carboxylic group there plus a OH group here. OH there and carboxylic group there gives you salicylic acid. When you talk about acetyl salicylic acid, or what we don't commonly know, this is the generic name, aspirin. Even when you say aspirin, everyone knows what aspirin is, can do the structure as the generic name. Then you acetylate the hydroxyl group of salicylic acid and you get acetyl salicylic acid. As I said, these are carboxylic acid. The carboxylic group is directly attached to the first hydrophobic area. We call this the first ring or a first hydrophobic area. So you can see directly attached, that gives us acetyl salicylic acid. Once you block the hydroxyl group, one, you improve on the taste of acetyl salicylic acid. It has a better taste than salicylic acid. Salicylic acid has a bad taste, so it's not highly palatable. Also, once you block this group, you reduce the acidity of this molecule, and therefore acetyl salicylic acid has slightly lower acidity compared to salicylic acid. So that is aspirin. Sodium salicylate, again, you can see the same. All the difference is now here you have have reacted, the carboxylic acid is the one you have reacted with a base. So this is sodium salicylate. So when you remove this group here, the sodium, this is actually the structure of salicylic acid, right? Then the next one is sodium thiosalicylate. Sodium thiosalicylate, the only difference is the hydroxyl group of salicylic acid has been replaced with an SH. And of course, the carboxylic acid remains. You will note that in all these drugs, apart from, of course, the ones we are calling the non-selective and the non-acidic group. Then you have the magnesium salicylate. This is a complex. This is a complex whereby you can see this one molecule of salicylic acid and another molecule of salicylic acid. So this is a COH. It bonds with the magnesium ion. It's a chelate. And then the hydroxyl group bonding the magnesium ion. This, of course, being a dative bond. This here, usually the hydrogen should not be there that more often than not being ionic bond. So then again, in that carboxylic acid from the other salicylic acid bonding there, and this one bonding there. So this is what we call magnesium salicylate. So when it gets in the body and it's hydrolyzed, it will give you 2 salicylic acid moieties. Then you have salicylate. When you look at salicylate again, salicylate. So salicylate again is 2 salicylic acid molecules. Wow. You can see this is a carboxylic acid of the salicylic hydroxyl group. So you have the hydroxyl group. So salicylate is where you have esterification. So you have that hydroxyl group of one salicylic acid undergoing esterification with the carboxylic group of another. So that's salicylate. Again, when it gets into the body, to be hydrolyzed to give us 2 salicylic acid. Then you have benorate. Benorate is a combination of salicylic acid and acetaminophen. Acetaminophen is paracetamol. So you find this is a completely different structure here. Paracetamol has an NHC double bond. It's an acetyl. It has an acetyl amino group there. It's an acetamide. So it has an acetyl amino group there. You can see that. And it has a hydroxyl group. Para position. So please note that this is completely different. This is a different molecule. That is paracetamol, acetaminophen. So that is paracetamol there. And the paracetamol is combined. Paracetamol is combined with acetyl salicylic acid. You can see this molecule here is acetyl salicylic acid. C double bond OCH3, that is there. And this. So the hydroxyl group of the paracetamol esterified with the carboxylic group of acetyl salicylic acid, and of course that group is free. So again, when this gets into the body, cleave to give you paracetamol and also salicylic acid. Paracetamol for pain, and of course the salicylic acid good for inflammation, pain, and fever. So those are the main. You can see all of them as we have correctly put. Even if they are esterified, when they get into the body, they will be cleaved and release our carboxylic acid. So you can see our carboxylic acid is directly attached to the benzene ring. So those are the salicylates. So the next class I was going to look at, it's just to make sure that you understand what we are talking about. So the other class mentioned, I think we mentioned the acetic acid derivatives. All this we're going to look at them. Those are all the salicylates, acetic acid derivatives before you go to the phenamides. Yes, acetic acid derivatives, one of them being indomethacin, solid. That. So if you look here, this is a structure of an example of acetic acid derivative. I just want you to understand, so that as we move on, you do understand when you talk about acetic acid derivative. You can see this is a carboxylic group. This in the salicylates was directly attached here. But now you can see it is separated by a CH2 group. And when you look at that acid, it is acetic acid. So that's why we are calling them acetic acid derivatives. Then we said you can have aryl or heteroaryl. If you look at indomethacin, indeed, this acetic acid is joined to this ring here. In fact, we can consider the whole ring. This whole ring, we call it the indo ring. This indole ring is a hetero. You can see it has a nitrogen, but it is also aromatic. So it's a heteroatom, which is aromatic, and that is where the acetic acid is joined. You can see these are acetic acid there, joined to that group. I only want you to understand why are we calling them acetic acid derivatives, calling others propionic acid derivatives. So let us now go. That will represent the acetic acid derivatives. Then the next one will be the propionic acid derivatives, where we have our ibuprofen. All these are acetic acid derivatives. Next one will be oxaprozin. All those are acetic acid derivatives. Diclofenac. Yes, now here we are. So now the next one is what we have called the profens, or what we have called the acid derivatives. Kindly note the difference here. For the acetic acid derivatives, they do not have this methyl group here. For all the profens or propionic acid derivatives, you can see it has that carboxylic acid, it has that carbon which is in the middle, but there is branching. So if you look at this acid here, it is actually propionic acid. CH3, CH, CO, C carbox, and the carboxylic group. So that is a propionic acid. The reason why we call them a propionic. Again, look at that, the same, look at that, the same, look at that, the same. There might be differences like this, we are going to discuss it. It might look different, but it is still very similar when it's those structural differences that are allowed with retention of activity. Then from there, from the propionic acid derivatives, we will look at the phenamates, which I believe I've left behind. Phenamates. All these are acetic acid. So the other ones will be the phenamates. I just want you to understand the differences in their structures so that even when now you draw them, you are aware what the differences are. You have the phenamates. Here are the phenamates. You have mecrophenamic acid. So here are the phenamates. If you look at the phenamates, like mefenamic acid, meclofenamic acid, again now, that's what I was saying, similar in terms of the carboxylic acid joining into the hydrophobic group, they are similar to the salicylates. But kindly note the difference that this would have been the hydroxyl group in the salicylates, but that hydroxyl group has been replaced with an amino group. And indeed, that compound there is what you call phenamic acid, is what you call anthranilic acid. That is the anthranilic acid, and all these drugs will be, so now on this amino group, you add a second phenyl. So that the major difference in their structure is on the substituents that are found on the second ring, but the first ring must remain the same. And that's why these are the anthranilic acid derivatives, all the phenamic acid, the phenamates. So I hope that is clear. Then another class you're going to look at is the enolics. I'm sorry, I'm doing this because you do not have your structures. I'm sorry I sent them late because I forgot to tell you to draw. To look at the enolics, where we have now piroxicams and the pyrazolone derivatives. Piroxicam, I hope. Whether they are in these notes, I hope so. Phenoprofen, ketoprofen, all these profens are acetic acid, are propionic acid derivatives. I don't know whether I have any. Nabumetone. This is a nabumetone, which I had said. If you look at nabumetone, this is a structure of nabumetone. Kindly note, it does not have a carboxylic group. And that is why we are calling it non-acidic. But because of this structure, you find in the body it is acted on and it is cleaved or it is oxidized so that it gives a carboxylic acid on that carbon. But nabumetone, you can see, is what we did mention. It's a non-acidic, but it is a prodrug. It does not have any activity. I don't know whether I have any of the other drugs. Phenoprofen, these are the same. That's the last one. So I do not, because you see the piroxicam, I'll discuss them under the next group. But at least you have seen when we talk about the difference in the structures, the acetic acid I mean the carboxylic group, I hope you have understood when we are talking about where it is joined. That really does matter a lot. So when I give you this, when you go back, please make sure you print all those structures and try and check out the difference between these different classes. I think, yeah, we have seen, I've shown you acetic acid derivatives. We have looked at the structure of indomethacin, and you have seen it is indeed an acetic acid. And all we are saying is that the acetic acid derivatives can further be divided into classes. We have what we call the indo and indene derivatives. Indo, an example is indomethacin. Indene, an example is sulidac. Indomethacin for indo. Also, etodorac is also an indo. I didn't write this. Indene is sulidac is an example of an indene derivative. We will see the difference that indo has a nitrogen, and for indene, the nitrogen has been replaced by a carbon with retention of activity. Then we have the pyrrole ring, which also indo. It's where we have seen the bicyclic ring. You have a phenyl ring joined to a pyrrole ring. That is an indo. Then you have the pyrrole ring alone, where you have aromaticity and a nitrogen. And we have drugs like tometin, somepira, ketorolac, all of them have that kind of ring. We're going to look at them. Then you have the oxazole. Remember, an oxazole is where you have an oxygen and nitrogen in, again, an aromatic 5-membered ring. Aromatic 5-membered ring with an oxygen and nitrogen is an oxazole. And we have an example of oxaprocin in that class. Then you have the phenyl acetic acid derivatives, and the phenyl acetic acid derivatives, where you have diclofenac, all it means is that you have a phenyl ring which is joined to an acetic acid. Phenyl ring joined to an acetic acid. Again, we are going to look at each and every structure, so I don't think we'll have a problem. Propionic acid, we have the profens, phenoprofen, flabiprofen, ibuprofen, ketoprofen, ketorolac, again, sometimes classified here, and occasionally classified as a non-classical acetic acid derivative. We have naproxen, we have oxaprocin, sometimes the classification, but for us, we will classify oxaprocin, and ketorolac, non-classical acetic acid derivatives, and I'll explain why we call them non-classical. Then we have now, of course, I've shown you the phenamates or anthranylic acid derivatives. I've told you why the anthranylic acid, they have that phenyl ring, carboxylic acid amino group, or they're also known as phenamates. You have mefenamic, meclophenamic acid, and flufenamic acid. All these 3 drugs only differ in the second ring. The second ring, the substituents in the second phenyl ring. Then you have the pyrazolone derivatives, also, which are also enolics. So the pyrazolones also, which are enolics, and the pyrazolone also, they also known as the 5 pyrazolidine diones. We have phenylbutazone, oxyphenbutazone, and so on. And then you have the aniline derivatives, paracetamol. I think I have forgotten there is the oxycams, which will be the same class here. The pyrazolone derivatives, we do not classify them alone. We classify them as enolics, the way we said, enolics, where you have the pyrazolone derivatives, also known as the 3,5 pyrazolone diones, and also you have the oxycams, where you have piroxicam, meloxicam, and so on. Don't worry, by the end of it all, you will have known all of them. It takes just a bit of time. Utapata zote. So that classification, as we have talked, is a sparse structure. And indeed, I have given you all the structures. When you leave, you will just look at those structures, and for each drug, because they are on different pages of the handout I've given you, put its class, structural class. So on every drug that you have, put its structural class so that you understand. And you can't be able to derive or to get the class from the structure just by closely looking at the structure and seeing, is it an enolic? Is it an acetic acid derivative? Is it a carboxylic acid derivative? Is it a propionic acid derivative? That you should be able to do. Then we can also classify the non-steroidal anti-inflammatories depending on their mode of action. no mode of action. We do have those which are selective. We have those which are non-selective. We do have those which are preferentially. They have more binding on COX-2, but they are not completely selective. They bind both COX-2 and COX-1, but they bind more strongly to COX-2, so we say preferential COX-2 inhibitor. So we can divide them according to the mechanism of action, and we can have the non-selective reversible COX inhibitors, non-selective, meaning they do not select. They'll go for COX-1, constitutive, COX-2, constitutive, and even COX-2 non-inducible. So they will go for all of them. And the one which is non-selective, note here this word here, irreversible. Irreversible means they bind permanently. And once they bind the COX enzyme, they will destroy it until more is regenerated. An example of that is aspirin is the only known member of this group. And that is why all of us know aspirin has a lot of toxicity, especially GIT irritation. It is an irreversible binder or an irreversible COX inhibitor. Then we have the non-selective reversible, means that it's competitive inhibition. Their binding of the COX enzyme is dependent on some factors like concentration. They are competing for the same enzyme with, of course, the arachidonic acid. And if you increase their concentration, they'll bind more, but they'll bind and then leave. So they can't give some room for binding over arachidonic acid. So the reversible competitive inhibition, where inhibition is highly dependent on concentration. You have drugs like ibuprofen. In fact, most of the others belong here. Then you have preferential COX-2 inhibitors. Like when you go out there in the market, you will find a drug like meloxicam. Meloxicam, which is an enolic, which is an oxycam. There is piroxicam, there is meloxicam. You find meloxicam has lower GIT irritation, or causes lower GIT irritation. The reasons why meloxicam causes lower GIT irritation is because it has higher binding to the, as compared to COX-1. So it has higher binding to COX-2, preferential binding to COX-2. So it still leaves the constitutive COX-1, so that the constitutive COX-1 can continue doing the work it does best. But it will bind some of it, but it will leave some, because preferentially it is binding COX-2 more than COX-1. So we have a Todorac there, meloxicam and napimetone. However, in vivo, both mechanisms 2 and 3 are essentially the same. This are essentially the same. It is only that one has better binding or higher binding to one enzyme than the other. And finally, we have the selective reversible competitive inhibitors, that's COX-2, where we have celecoxib, etoricoxib, rofecoxib, and valdecoxib. We are going to look at them in details and ask ourselves, why are they selective? Why are they selective? When we say they are selective, kindly note, we are saying they are going for the inducible COX-2, and they leave your COX-1. They leave your COX. They go for the inducible COX-2. They do also, unfortunately, will also bind the constitutive COX-2, and they also have been found to have some toxicity, like cardiovascular toxicity. These agents induce a slow conformational change in COX-2, but not in COX-1. The change increasing the inhibitor affinity by binding very tightly and dissociating very slowly. That's what when you say good binding is when a drug binds strongly, dissociates slowly. The isoenzyme selective induction of that. So with the exception of aspirin, all the non-steroidal anti-inflammatories are reversible competitive inhibitors. We've already said that aspirin is an irreversible binder. Aspirin is a non-reversible inhibitor for it acetylates. Look at this word, acetylate. You see that acetyl group? It acetylates the active site, which is a basis for its prophylactic use to prevent heart attacks. So it acetylates the enzyme, and once it acetylates the enzyme, it is an irreversible binder. Of course, do remember that we have prostacyclin and thromboxanes, and this also control clotting mechanisms, and most of the heart attacks are as a result of the clotting of clot. So you find that the aspirin will bind irreversibly or will block the same block the conversion of arachidonic acid into the prostaglandins almost irreversibly. The cytoprotective role in the stomach and kidney is largely due to the vasodilating properties of the prostaglandins, which enhance mucosal blood flow. So that is in the stomach. They also produce mucus. So the cytoprotective role in the stomach and kidney is largely due to the vasodilating properties of the prostaglandins, which enhance mucosal blood flow. Remember, we did say some prostaglandins have vasodilatation, especially the prostaglandin I2, that is the prostacyclin. COX-1 produces prostaglandins that exert cytoprotective roles. COX-2 produces prostaglandins involved in inflammation, fever, and pain, and COX-2 activation leads to inflammation. So that is the main difference. COX-1 is protective, controls the homeostasis, but as I said, also we do have COX-2, which is constitutive and which is important, but majorly the COX-2 is inducible. So it's good to note, I would want you to add in your note that also we do have COX-2. It's good to note that we do have COX-2, which is constitutive. So COX-2 is inducible, and also we do have COX-2, which is constitutive, but it is restricted to discrete regions. So we do have COX-2, which is also constitutive, restricted to discrete regions like the kidney, GIT, and the brain. But COX-1, we are saying, is constitutive, and it is expressed throughout the body. So we have COX-2, which is inducible, and also we have COX-2, which is constitutive, and the constitutive COX-2 also has the therapeutic indications, but the COX-2, which is constitutive, is also restricted within certain regions in the body, namely the kidneys, the GIT, and the brain. The COX-1, which is constitutive, is widely expressed throughout the body. So I needed you to add that point so that you say that it's only COX-1 which is constitutive. We have some COX-2 which is constitutive but restricted in the kidneys, the brain, and the GIT. We are noting that the non-selective, non-steroidal anti-inflammatories, you bind both COX-1 and COX-2, interacting with the hydrophobic channel of COX, the COX isoenzymes. You're going to look at the enzymes. When you look at the enzymes, they do have, if you look at those structures, we are to look at the structure of, I hope you can be able to draw the structure of aspirin, and you can draw the structure of acetylsalicylic acid. They have the phenyl ring. That phenyl ring is a hydrophobic center. If you look at all the drugs, the structure I've shown you, they either have one ring or two rings. Those phenyl rings are hydrophobic centers. And those are the areas we are saying that this enzyme, whether COX-1 or COX-2, will interact with the hydrophobic channels of these COX isoenzymes. Isoenzyme meaning you have the COX-1 and COX-2. So they bind those hydrophobic areas within these drugs, within the hydrophobic areas, within the enzymes are bound by this drug, which means for them to bind a hydrophobic area, they also must have a hydrophobic area, because hydrophobic areas are usually bound through hydrophobic bonds. And when we look at the structure of, you're going to look at the structure of arachidonic acid and look at the structure of the non-steroidal anti-inflammatories, you see similarities in the structure of the two. Arachidonic acid will have hydrophobic channels. The non-steroidal anti-inflammatories have hydrophobic areas which will bind the hydrophobic channels of the COX enzyme. Non-selective, non-steroidal anti-inflammatories compete directly with arachidonic acid, inhibiting cyclooxygenase activity in a reversible manner. I'm only giving now the details. They are competing with arachidonic acid for the same site. Therefore, structural similarity. Aspirin, unlike other non-steroidal anti-inflammatory, irreversibly acetylates a serine residue in both COX-1 and COX-2, preventing arachidonic acid from reaching the catalytic site. So if you look at the structure of aspirin, the hydroxyl group has been acetylated. So when that aspirin gets close to the COX enzyme, whether COX-1 or COX-2, these enzymes have a serine moiety. Remember what is a serine moiety? A serine moiety has a hydroxyl group. So all that happens is that the acetyl group from the that acetyl group is transferred to the serine moiety of the enzyme. Serine moiety of the enzyme. Once that happens, you block or you introduce steric hydrans, that enzyme cannot bind arachidonic acid. And once it cannot bind arachidonic acid, of course, no synthesis of our prostaglandins. The non-steroidal anti-inflammatories do not affect the peroxidase site. Remember, when we were looking at the cyclooxygenase enzyme, cyclooxygenase enzyme has two areas. It has an area, it has the peroxidase area, which converts the prostaglandin G2 to H2. G2 to H2 is just removal of one oxygen. And this is still done by the same enzyme. The first portion of the cyclooxygenase enzyme brings about cyclization and the oxidation. So there is cyclization and the oxidation. And the oxidation a peroxide. So it gives us a peroxide, then conversion of that peroxide to a hydroxyl group, which is found in all the naturally occurring prostaglandins, is by the peroxidase side of the cyclooxygenase enzyme. So we do not have two enzymes. It is one enzyme, the cyclooxygenase enzyme, but with two different portions, and those two different portions have two different jobs. One portion, cyclization and oxidation. The other portion, actually reduction, so that it converts the peroxidase to the peroxide, converts the peroxide into a hydroxyl group. So we are saying the non-steroidal anti-inflammatories do not interfere without that second site of the cyclooxygenase enzymes. Then now, we are just mentioning the drugs because we have mentioned quite a number of names. The coxibs, which we have said are selective inhibitors, and these coxibs will preferentially inhibit COX-2. They will go for COX-2. They will your COX-1 intact. And again, why do they do that? They are able to do that because of the structural difference between COX-1 and COX-2 enzyme. Structural difference between COX-1 and COX-2 enzyme, and there's also a structural difference between the coxibs and the other drugs. So please note, structural difference between the and also structural difference between the enzymes. So it is a structural difference between the enzyme stimulated. It's that stimulated to be able to come with a molecule that can choose or that can select COX-2 but not COX-1, because the enzyme COX-1 and COX-2 have a structural difference. So the drug that was synthesized also has a structural difference, and it has a portion a rigid portion that can directly go for COX-2 but not. So coxibs are selective agents because they bind COX-1 poorly and in a rapidly reversible manner, whereas they bind COX-2 more tightly. Preferential inhibition of COX-2 is thought to be due to the additional space in the COX-2 hydrophobic channel. Note here, there's an additional space in the COX-2 hydrophobic channel, as well as the presence of a side pocket. We will note that this side pocket within COX-2 is because there is a difference in the amino acid that is found in COX-1 and COX-2. One has valine, another one has isoleucine. You're going to see that in a minute. The side pocket can discriminate the coxibs from non-selective agents based on the different overall structures of these agents, in particular by the presence in coxibs of a specific side chain. So we are only saying, as I have already mentioned, the coxibs have a structural difference from the other anti-inflammatories, from the non-selective. Number two, the enzymes themselves, the COX-2 has a larger hydrophobic area, and it has a pocket. And because of those structural differences, you have that these enzymes, these drugs, go for COX-2 and not COX-1. So look, let us just, I'm not telling you, are not supposed to, of course, to draw this, but it's just to make you understand what are we talking about when we say the structural difference between COX-1 and COX-2. This is COX-1, and this is what we are saying, an extra hydrophobic area. You can see COX-2 has a huger hydrophobic area. Number two, you can see COX-2 has this pocket. This is what we are calling the pocket. And if you look at this pocket, you look at this enzyme, it is valine. That is valine. This, so not enzyme, amino acid. That's amino acid valine, and this is amino acid. Position number 6, amino acid isoleucine. When we look at the structure of isoleucine, isoleucine is more bulkier than valine. And because isoleucine is more bulkier, it blocks the space as compared to valine, which is slender and smaller, and therefore giving us that pocket. So because of that structural difference, where you have this pocket, then the selective coxibs are able, they have been synthesized with a rigid arm, with a rigid side chain. That rigid area is able to come and insert itself in this pocket. And of course, also, they are also able to bind much better on the larger hydrophobic area. But the main thing is that the coxib will come and insert themselves, be able to get into this pocket, which you do not have in the COX-1. So they are not able to bind. Even if they bind these, they bind it very loosely, will dissociate very quickly, very rapidly. But when they come and bind here, they bind strongly, and therefore will inhibit the COX-2. So that is telling us of the importance of the fact that, the relevance of the fact that the structure of COX-1 and the structure of COX-2 are very different, allowing for synthesis of specific molecules which can go for COX-2. When they go for COX-2, it means your COX-1 is paired, and once COX-1 is paired, it is still available to produce for you the that bring about homeostasis or that protect the body, and therefore lesser toxicity. But as we have said, the COX-2, unfortunately, also the selective coxibs will also bind the inducible COX-2, which also has its role, and that is why it has been discovered that they can also bring about some toxicity, including kidney problems, or cardiovascular issues. So this is just what we have. So we are saying you have the non-selective COX inhibitors. They will go for COX-1, which is constitutive. They will also go for COX-2, especially the constitutive. So they will also go for the constitutive COX-2. And therefore, in doing so, the non-selective, in doing so, you can see the role of COX-1. GI cytoprotection, platelet aggregation, renal electrolyte homeostasis, renal blood flow maintenance, renal electrolyte homeostasis, renal blood flow maintenance. So all this negatively affected when you give the non-selective COX inhibitors, and no wonder quite a lot of toxicity. When now you give the selective COX-2 inhibitors, they will go for the inducible COX-2. They will leave the COX-1 free. They will go for the inducible, of course. They will go for the inducible, and they will also go for the constitutive COX-2. They will go for the COX-2, and they will help us in, of course, a bit of toxicity, but they will help in relief of pain, fever, and inflammation. Because we are saying it is the inducible COX-2 that is responsible for pain, fever, and inflammation. It is not the constitutive COX-1. It is not the constitutive COX-2. It is the inducible COX-1, COX-2. When you have an injury, that is the COX enzyme, the enzyme that is produced, and it brings about production of prostaglandins that are responsible for pain, fever, and inflammation. Now here, back, and we have this diagrammatically is our arachidonic acid. So you can see our arachidonic acid has a carboxylic acid, has a carboxyl group. And no wonder, and remember I have said that for most of them, especially the non-selective, do have that anionic site in terms of a carboxylic acid, because they need to go and bind the portion which is bound by this portion. So this portion here must be cationic. Within the COX enzyme, this portion must be cationic, and which is bound by the anionic site of the carboxyl group. So that portion there must be cationic. That similarity is needed to help us bind. Then you can see this portion here between our double bond 5 and 8 there. This is an area we call our fast hydrophobic area. And this fast hydrophobic area corresponds This fast hydrophobic area usually corresponds with our fast hydrophobic ring. So you can see here, this is a fast hydrophobic ring. This is a structure. This is the structure of indomethacin. So this is our fast hydrophobic area. This hydrophobic area, of course, is an indoor ring. It's a heteroaryl ring, and it is assumed, or it is thought, that the area of the arachidonic acid, position number 5 to 8, there is in that area, and the area, the fast hydrophobic ring of the non-steroidal anti-inflammatory, let's say, for example, indomethacin, and that area will bind a certain hydrophobic portion found within the COX enzyme. So that area, the fast hydrophobic area, and also position 5 to 8 of the arachidonic acid, corresponds to a certain hydrophobic area within the COX enzyme, and again allowing for very good binding hydrophobic bonds. Then you have the second area here, which is the bond at position number 11. That again bond at position number 11 is said to correspond with the second hydrophobic area. Second hydrophobic area within, not all the non-steroidal anti-inflammatories have a second hydrophobic areas, but majority of them do have a second hydrophobic area, and it corresponds to a certain position or a certain site within the COX enzyme, a second area within the COX enzyme. And therefore, what are we saying? This is just telling us there is structural similarity between arachidonic acid, the non-steroidal anti-inflammatory, and the COX enzyme. Why? Because all of them, the non-steroidal anti-inflammatory and the arachidonic acid, are competing for the same sites. They are competing for the same site. They are competing for the same enzyme. So if one is to replace the other, there must be structural similarity. And because of that structural similarity, what is allowing for the non-steroidal anti-inflammatory to go and bind the COX enzyme and block the arachidonic acid from accessing that site, and therefore block the synthesis of the prostaglandins, and hence, of course, stop pain, stop fever, and also stop inflammation. So now you're looking at the COX binding site, which we have already said. So you have a cationic center, and I have shown you cationic center is what we have said, because on arachidonic acid, it's an anionic site. The corresponding site must be cationic on the COX enzyme. A cationic center and two hydrophobic areas. And we have talked about, we've talked about the two hydrophobic areas. There is this hydrophobic area, and there's that hydrophobic area. And those are represented by that, and the other one, as I have already explained. So it has cationic center and two hydrophobic areas. The cationic site is attributed to a guanidinium group on arginine. You can draw the structure of arginine, and if you draw the structure of arginine, you will see it has a guanidinium area. Guanidinium area is because it has an amino group, a free amino group, which at physiological pH will be protonated. And once that area is protonated, then that area will be positive. So that is what gives the cationic site within the COX enzyme. The first hydrophobic area is located adjacent to the cationic center. This aromatic system appears to correlate to the double bonds at position 5 and 8 of arachidonic acid. I've already. The second region lies under and out of plane. That is very important. That the first hydrophobic area and the second hydrophobic area are not on the same plane. And we will discuss as we look at the drugs. How is the structure of the drug such that the drugs, the first ring and the second ring, are not in the same plane. They do not have coplanarity. The first and second ring are not in the same plane. They do not have coplanarity. One of the ring is facing one side, the other ring is facing the other side. They are not on the same plane. They cannot form a plane when you look at them in a three-dimensional, there's a three-dimensional structure. And this is necessary because the COX enzyme itself, the second hydrophobic area and the first hydrophobic area are not in a plane. So if these drugs are going to bind these two areas, they must also. So this point is very important. The second region lies under and out of the plane with the first hydrophobic area and is commonly referred to as a trough. The second lipophilic area may correspond to the area of the double bond in position 11 of arachidonic acid. We have discussed everything. I hope in your mind now you can see this arachidonic acid, which has a cationic center, has a hydrophobic group, and then it twists, and it has the second hydrophobic area, which is out of plane with the first hydrophobic for binding, and even drawn the guanidinium moiety for you. So look at that. So we are saying here is our guanidinium moiety, and as I had said, it has this amino group, and at physiological pH, these are a basic area. At physiological pH, this amino group will be protonated, and once it is protonated, then it will give the COX enzyme at that position. At that position where you have the guanidinium moiety, it will give the enzyme a center through protonation of the guanidine or of the adenine moiety. So that is adenine with that guanidinium moiety, protonation at physiological pH. COX-1 and COX-2. We don't really have to know which residue is where, but we are saying COX-1 residues, adenine 120 in tyrosine, 355 stabilize the anionic group present in most non-steroidal anti-inflammatories. All we are saying is that when this drug comes in, it will be stabilized by a particular site, and that's what we have called the adenine and tyrosine. So these groups, these two amino acids, will have positive areas which will stabilize the anionic group present in most non-steroidal anti-inflammatories. That's all we are saying. So we are just highlighting the fact that the COX enzyme has a cationic center, and that cationic center will be able to attract, will be able to hold the anionic site of the drug or of arachidonic acid in place within the COX enzyme. Non-steroidal anti-inflammatory aromatic rings are accommodated in the hydrophobic channel. All we are saying, we look at the aromatic rings. We have talked about hydrophobic 1, hydrophobic group ring, hydrophobic ring 1, hydrophobic ring 2. Where do they go? They go to the hydrophobic channel of the COX enzyme, because like attracts. So this is a like area with the hydrophobic, a lot of hydrocarbons, and therefore hydrophobic areas. It will go for an area which is, because those ones interact through what we call hydrophobic bonds. Serine 530, we don't have to remember the number, is the residue acetylated by aspirin. Note the presence of the relatively bulky isoleucine. This isoleucine is what we have said found in COX-1, not found in COX-2. And that bulky isoleucine is the one which prevents the formation of a pocket, and in COX-2 allows for formation of that pocket. In COX-2 residue also are present, so that is the same. However, residue 6 is valine, which allows opening of a side pocket. This pocket accommodates the sulfonamide or isostere of COX-2 inhibitors. As I said, the selective COX-2 inhibitors, the selective COX-2 inhibitors or selective inhibitors have a sulfonamide. We will see either they will have a sulfonamide or they will have a methyl sulfone. So they have a rigid group. Yeah, I hope you can remember the structure of a sulfonamide. The structure of a sulfonamide will have S double bond O, and NH2. NH2 joined to a sulfur, and the sulfur has a double bond O and a double bond O. That is what we call a sulfonamide. That sulfonamide is a rigid structure. That rigid structure, which is found in the COXIBs, or which is found in the selective non-steroidal anti-inflammatories, goes and fixes itself in this pocket, is accommodated in this pocket that we are talking about. And as you can see, these are the two amino acids. When you look, this is valine. You can see that is valine, and you can see this is isoleucine. You can see isoleucine has an extra methylene group there, much more bulkier than valine, and this bulkiness is what prevents the COX-1 from having the pocket as opposed to the COX-2. So this slender, this smaller COX-2 to have a pocket, and like the COX-1, which has isoleucine and therefore no pocket. The overall structure and catalytic activity of both are similar. overall structure. When you look at the overall structure, some of those minor differences that we have mentioned, but the overall structure and catalytic activity of both are similar. There is some distinction or differences in their regulation and expression. Expression is how they are synthesized and how they are regulated and expression. COX-1 is constitutive and its expression is regulated by hormonal signals involved in maintaining physiological homeostasis. So COX-1 is constitutive and its expression is regulated by hormonal signals, not by stimuli from outside because you have had an injury. This is by hormonal signals involved in maintaining physiological homeostasis. Also the COX-2, the constitutive, there's a bit of, as I said, and I'll continue repeating, COX-2, which is constitutive, and even that will be regulated by hormonal signals. But COX-1, and then of course, COX-1 is also expressed in all tissues. COX-1 is also expressed in all tissues, but we are saying COX-1, but not COX-2, is constitutively expressed in the stomach where it is involved. But now I have read a little bit more, and there's a bit of COX-2, as I have said, which is constitutive, but it is restricted in some areas. But COX-1 is found everywhere. COX-1 is found everywhere. There is, of course, the COX-2 inducible, but COX-1 is only constitutive. We do not have an inducible COX-1. COX-2 is the one which you have a bit of inducible, which you require for therapeutic activity, but you also have, no, not the inducible, you have the constitutive, which you require for therapeutic activity, and then you have majorly the inducible one, which brings about the effects that we do not want. So we are saying COX-2 expression and activity is largely responsive to adverse stimuli such as inflammation and physiologic imbalances. COX-2 has a binding site for steroids, whereas COX-1 does not. Control of COX-2 transcription and translation is thought to be the primary mechanism by which steroids such as hydrocortisone and dexamethasone bind this enzyme. Remember, we have said COX-2 has a site for steroids, COX-1 does not. So because the steroids can bind the COX-2, then they can also modulate that enzyme. COX-2 is constitutively expressed notably in the brain and the kidney. So this, I didn't even know I have that point here. So we are still saying there is some COX-2 which is constitutively expressed, but in restricted areas like the brain and kidney. But COX-1 is all constitutive all over the body for the protection of the body. Then we have the COX-2 inducible, which now brings us all the problems that we do not want. So that's why we are saying you want a drug that goes for COX-2. Is there any question up to there? Because that is the basis of what we are doing. Do you have any question, or are we good to go? We continue. It's like I'm getting a cold. Now, mechanism of action. So if we look at this, is something we are just repeating the same. It's just good to put it down. So you have the membrane phospholipids, and you have release of phospholipase A2, which we did mention again because of because of a stimuli. As we have said, it can be also a physiological imbalance triggers release of phospholipase A2. The phospholipase A2 you cleave the arachidonic acid from the phospholipase. Remember, we talked about phosphatidyl inositol, phosphatidylcholine. It will be cleaved, and once it's cleaved, you get your arachidonic acid, or Icosapent tetraenoic acid. It has 4 double bonds, Icosapent tetraenoic acid, and the Icosapent tetraenoic acid can be converted to prostaglandins associated with this should be pain, fever, and inflammation through action of the inducible COX-2. All can be converted into the prostaglandin associated with GI mucosa integrity, platelet function, renal function, and what have you through action by COX-1. So all we is that if you look at the traditional non-steroidal anti-inflammatories are the non-selective non-steroidal anti-inflammatories. They block here. So they are blocking. They will block the COX. They will block our COX-2. They will also, as you can see, that traditional moves across. They will block our COX-2 there. Our COX-2 there. They will also block our COX-1 there. And once they block both enzymes, they're blocking both COX-2 and COX-1, then you can see they will stop the pain, the fever, and the inflammation, but they will also be responsible for a lot of toxicity. The COX-2 selective inhibitors will mainly block the COX-2 enzyme. We have said, of course, they block the COX-2 inducible and the COX-2 constitutive, and therefore will be responsible for a little bit of toxicity. Just 1 minute, just 1 minute. Sorry for the interruption. Okay, so yeah, I believe we have understood the whole of this. That is a mechanism of action for the non-steroidal anti-inflammatories. Sorry, again, there's something I had to sort out. So we are looking at the mechanism of action, and we have understood it. So inhibitors of cyclooxygenase reduce the amount of prostaglandins and thereby reduce the inflammation process. Now, what are the main side effects? What are the reasons of quite some of the main side effects? Some of the main side effects, one, of course, is gastric irritation. How does gastric irritation occur? Gastric irritation can occur because of two reasons. One, these drugs are acidic in nature. They have a carboxylic group, salicylic acid, indomethacin, all of them have a carboxylic acid. They are acidic in nature. So when they get into the stomach, they will be ionized. They will be ionized and a small portion non-ionized. The small portion which is non-ionized is able to pass through the mucosal membranes of the GIT and get into the cells. Within the cells, the pH is 7.4, slightly alkaline. So you will have quite a lot of the drug non-ionized, and therefore, slightly alkaline, you will have the drug still ionized. The drug which will be ionized within the mucosal cell will be trapped within the mucosal cell. Once the drug is ionized within the mucosal cell, ionization means the drug will release hydrogen ions. The hydrogen ions will increase the acid concentration within the mucosal cell. Means irritation, and that's how the irritation occurs, just because of the structure of these drugs. The fact that they are acidic in nature, and therefore they will increase the concentration of hydrogen ions within the mucosal cells, and therefore result in gastric irritation. So we are saying the primary insult is ionized at stomach pH. If I please draw the structure of an acid, HA, draw a structure of an acid, HA, put an equilibrium sign, and put a hydrogen ion plus A minus. That's a HA. HA is a weak acid like these drugs. HA, equilibrium sign, hydrogen positive plus A minus. So in the stomach, because in the stomach the pH is acidic, there is very high concentration of hydrogen ions. So most of the drug within the stomach, weak acids or drugs that are weak acid in the stomach, will be in the anionized form. So what does that mean? Because there is a high concentration of the anionized form of this, most of it will be able to pass through the membranes and get into the mucosal membrane or mucosal cell, because the drugs that penetrate the membranes are usually in the anionized form. So the drug, as we are saying, that's why we are saying anionized at stomach pH that allows passage into the gastric mucosal cells. I'm explaining why anionized. An acid, as acidic drug in an acidic pH. Acidic pH means there is a high concentration of hydrogen ions. Remember, this is a weak acid, and weak acids are partially ionized, and the ionization of the weak acid is dependent on the environment, which is the environment acidic, is the environment basic. Weak acids in an acidic media will be less ionized. Less ionized weak acid drug will better penetrate the membranes because of the fact that it's ionized. So that's the first point. The inside there is a higher pH, which will allow ionize them, which cannot pass. So we are saying this sentence is as bad English, but we are saying inside the mucosal cell, the pH 7 is slightly higher. This has slightly higher pH, which is slightly basic, and the anionized acidic drug will be more ionized inside the mucosal cell because the pH is slightly going to the slightly basic 7.4. Now, once the drug is ionized, that's what we are saying, it will generate high concentration of hydrogen ions, so cannot pass. So it is ionized, And therefore, because it is ionized, it cannot pass out to stay within there. This alters the permeability of the cell membranes and allows accumulation of hydrogen ions, which causes cell damage. So once the drug penetrates, the pH allows for more ionization within the mucosal cell. And once it allows for more ionization, there is trapping of the acid. There is trapping of the hydrogen ions. Those hydrogen ions will be responsible for change of permeability. They will be responsible for damage of the mucosal cell, and that is what gives us the problem. So this is what we are talking about. If you look at this drug here is our weak acid, AR. Remember, it has an aromatic area, whether heteroaromatic or just another area. It has a carboxylic acid, so it has undergone ionization. We are saying in low pH, this is the microenvironment. This is the environment of the stomach, which has acidic pH. You can see there is more, this bold arrow here. The arrow towards the anionized drug is much bolder and bigger. The other one towards ionization is smaller. So anion fraction predominates. So we will have this predominating. And because it's predominating, it will pass through the GIT mucosa, it will pass through the GIT mucosa to get into the mucosal cell. So within the mucosal cell, you have the anionized drug. And once you have the anionized drug, within the mucosal cell, there will be more ionization of the anionized drug because the pH, intracellular pH, is a little bit higher. It's about 7.4. The pH of the stomach is about between 1 and 2. So that will now allow for the drug to undergo ionization. So ionized fraction predominates. And this ionized fraction, because again, it cannot penetrate, only the anionized drug penetrates the membrane properly. So that will be responsible for change of the permeability and, of course, damage of the cells. The secondary insult, so that is the primary insult. It is because of the fact that this drug is acidic. It moves in, gives us high concentration of hydrogen ions, and you know also the hydrogen ions. You have the potassium ATPase enzyme, which pumps them out. So as it pumps them out, this drug again will increase. So remember, hydrogen ions are pumped out in the last step of synthesis of hydrogen or hydrochloric acid in the stomach is a step whereby the acid hydrogen ions are pumped out against a concentration gradient action. I mean active transport. So these hydrogen ions which are generated can again be pumped out through active transport and increase again further, decrease further the pH of the stomach, again causing a lot of irritation. The secondary insult is the result of the mechanism of action. The inhibition of the prostaglandin synthesis prevent the cytoprotective action of the prostaglandin. So these are the two mechanisms which bring about insult or bring about toxicity of the non-selective non-steroidal anti-inflammatories. One direct insult whereby, because these drugs are acidic, they will increase the acidity within the stomach, they will increase the acidity within the mucosal cell and cause destruction of the mucosal cell, and hence, of course, the problem we are talking about. They will also block the synthesis of the protective prostaglandins and hence again cause gastric irritation. So this is the same non-steroidal organic acid, secondary insult, prostaglandin inhibition in the GIT, primary insult, direct acid damage, and that gives us a dual insult which results in gastric damage. Most of the gastric effects of the non-steroidal are attributed to the acidic character, which participates in decreasing surface hydrophobicity of the mucus gel layer with subsequent loss of barrier properties. As we said, one of the other things that the prostaglandins do is trigger secretion of mucus, and the mucus acts as a plaque. It acts to cover, to line the whole of the GIT surface, and as it lines the mucus, lines the stomach surface, and as it lines the stomach surface, it means the contents or the acidic contents of the stomach are not in direct contact with the mucosal membrane. But once you give the non-steroidal anti-inflammatories, they will decrease the surface hydrophobicity of the mucus gel layer, and therefore, once they decrease the hydrophobicity, it cannot stick. It cannot give you the protection. It can't be as thick, the thick the thick mucus to change, then the acidic stomach content will be in direct contact with the mucosal membrane, causing causing problems. There is also uncoupling of oxidative phosphorylation with subsequent increase in mucosal permeability and back diffusion of the hydronium ion. By back diffusion of the hydronium ion, we are saying the hydronium ion can go back, even through active transport, go back to the stomach, further decrease the pH, and of course, further causing GIT irritation. Ion trapping into the mucosal epithelium. The ion trapping is because, remember, the pH inside is a little bit more basic, higher pH compared to the outside. Therefore, these positive ions, these ions are trapped within the inside. They change the permeability of the mucosal membrane, they damage the mucosal membrane, and in that damage, that indeed is what is causing us the problems that we observe when we give the non-steroidal, the non-selective inflammatories. What are their chemical and pharmacologic properties? They are all relatively strong organic acids with pKa like that, most but not all a carboxylic acid. So we are only saying they are strong organic, but please note, when we say strong organic acids, we know that organic acids are usually weak. So their strength is not comparable to the inorganic acids like sulfuric acid, like hydrochloric acid, but they are basically strong inorganic acids because they all have the carboxylic acid, and we have the aspirin and also piroxicam. Piroxicam, these ones are acidic because of the ketoinotautomerism. Salt form can be generated upon treatment with base, and all of these compounds are extensively ionized at physiological pH. You have seen, like sodium salicylate, you can derivatize them into the salts, and you all know that we derivatize drugs into salt to improve on their water solubility, so that they get into the water, within the gastric content. Then it is only that which is in solution that can be absorbed. So when they get into that gastric content, again they form an equilibrium of what is ionized, what is unionized, what is ionized, what is unionized. The unionized molecule will move in and allow for more ionization until all the drug is absorbed. They differ in their lipophilicities based on their lipophilic character of their RA groups and additional lipophilic moieties. And so this we are going to see that all the structure of these non-steroidal anti-inflammatories, they have additional groups. Like we are talking about a molecule like diflunisal. You look at its structure, it has an additional aromatic, aryl group. It has additional halogens when we compare it to acetylsalicylic acid. And once you add more hydrophobic groups improve on the lipid solubility. Hydrophobic groups also will improve on the interaction of this drug with the second hydrophobic group, or therefore improve on the binding. So that's what we are saying. Their characteristics, their pharmacokinetics, absorption, and will also depend on their structure. When you have a drug which has a halogen, you know halogens will inhibit metabolism. And so all we are saying is that they have similar activity, but their pharmacokinetics may differ. Their absorption will differ depending on their structure. And the structure which will alter their pharmacokinetics is introduction of hydrophobic groups or halogens will improve on the absorption or the passage through the lipid membrane, and also decrease the metabolism of these drugs. The acidic group in these compounds serves as a major binding group, ionic binding with plasma proteins, and that is why, like the salicylates, salicylates cause a lot of allergic reaction, because that acidic group in these compounds, like carboxyl, the anionic group can bind the plasma proteins. If it binds the plasma proteins, it triggers allergic reactions because you form the allergen, triggering the allergic reaction. And that is why, like for salicylates, you must be very careful who you give those drugs. Even like ibuprofen, must be very careful. You cannot give them to people who are susceptible to them, or who have issues with allergenicity. Thus, all non-steroidal anti-inflammatories are highly bound by plasma proteins and can bring about drug interactions. That's another point. Drugs which are bound to plasma proteins, you must be very careful when you give other drugs concomitantly, when you give other drugs together or concurrently. So when you have drugs that bind plasma proteins, you must be careful which other drugs you give. Because if you give other drugs also which bind plasma proteins, then it means this non-steroidal anti-inflammatories will not be completely bound. And once they are not completely bound, it means their concentration in the blood will be higher than normal or than acceptable, than it is acceptable. And once their concentration is higher, that can be a source again of toxicity. So we are saying, one, their binding to plasma proteins can elicit allergenicity. Two, it can be a reason for drug interactions through competitive plasma protein binding. So you must be careful which of these drugs you give together. If you give them together, then you must be careful to reduce the doses of these drugs accordingly, so that you maintain the required concentration within the blood. The acidic group also serves as a major site of metabolism through conjugation. Yeah, whenever you have a carboxylic group, it's a site of metabolism. That's a major pathway of clearance for many non-steroidal anti-inflammatories is glucuronidation and inactivation followed by renal elimination. We're just looking at the structures. We are saying for those which have the carboxylic group is a highly polar group. It does not require that drug to undergo phase 1 metabolism because the carboxylic group is available. It will undergo glucuronic conjugation. Once you get glucuronic conjugation, the drug is highly water soluble, out it goes. And therefore, some of those drugs can have a short duration of action because of the presence of that group. And that group also binding plasma proteins, as we have said, allergenicity or even drug interactions. So when we look at the non-steroidal anti-inflammatory, especially the simplest, which are the carboxylic acids or the salicylates, this is what we have. This is what we are calling our fast hydrophobic center. And that hydrophobic center can either be directly connected to a carboxylic group or attached to a carboxylic group through an acyl chain. Like where we are talking about ibuprofen, we are talking about indomethacin. They are not directly attached to the carboxylic acid, but they are attached through an acyl chain. But what we want to depict, these drugs always will have one hydrophobic area, and they can be connected either directly to, this is our second hydrophobic areas. But sometimes, like if you look at the structure of ketotifen, you find, of febuprofen, you find that sometimes this hydrophobic group is connected to the second hydrophobic group through a polar group. So sometimes, but there are times it is connected directly. So we are saying that is a very, very general structure of the non-steroidal anti-inflammatories, but it changes as per class. As I have said, this is in agreement with the phenamates or tranexamic acid derivatives and the salicylates. All the others are not directly attached. They do have either acetic acid here or propionic acid. Then I have said this X is in agreement with some drugs where you can have an oxygen or you can have a carbonyl group. But there are those that, again, this second group is attached directly. There are some, like naproxen, where this second hydrophobic group is fused. Naproxen has a naphthyl ring. A naphthyl ring is a phenyl ring fused with another phenyl ring. So this might be a general structure, but it differs. It changes depending on the group you are discussing. But it's only important to tell us we do have a first hydrophobic group. We do have a second hydrophobic group. They can be fused. They can be attached a polar group, or the second one can be directly attached to the first one. And of course, they do have a carboxylic group, which is either directly attached or is separated, depending on the group that we are talking about, the class we are talking about. Do I have any question up to there? Any question? We good to go? Any question? We have any question? As we finish, let's look at also So that we are looking now, we're moving well, although we haven't done very much. But if we are looking at the general structure and property of non-steroidal, in general, non-steroidal anti-inflammatory structurally consists of an acidic moiety. We have said enough of that. More often than not, a carboxylic group. It can be a carboxylic group. It can be an eno, like the enolex. The enolex, we have the phenyl butazone, or the pyrazolones, pyrazolones, or the oxycams, where we have piroxicam attached to a planar aromatic functionality. So look, the first one is planar. It is in the same plane as this group that is coming in. Some analgesics also contain a polar linking group which attaches the planar moiety to an additional lipophilic group. This is like this one. I've given phenoprofen, which has an X. It can be an oxygen, it can be a carbonyl group. Phenoprofen has an oxygen at that as an X. That can happen. But there are others, like the carboxylates, whereby, and you can see here I've drawn it. So like the carboxylates, where this group is directly attached. Like when we look at diflunisal, the salicylates, remember, have only one ring. When we look at diflunisal, we see diflunisal has a second phenyl ring, which is also with halogens, as I have said, and that is directly attached to the aromatic ring. It is not attached through a polar group like in phenoprofen. So you're saying it can happen this way, or it can also happen that way. And even I've said it can also happen another way, where this one and this one are fused together. That is just the general structure and property of the non-steroidal anti-inflammatories. Can we continue, or you want us to edit there? Done much. Communication from you. Do we edit there, or do we continue a bit? What is your choice? Hey, are those ones who are already offline? We had their class. Can I have communication from you? Today I've not been asked you questions. We continue. What's your opinion? Brave. Yeah, we stopped there. Let me find you. Let me get more of your responses. Then let us now appreciate that you are there. Have we understood? Are we okay? Thumbs up or yes or whatever sign you want to use to sign in that you are there throughout the class and you appreciate what we have learned. Or if you have questions, if you have not understood, it's also good to say you didn't understand. So I need all of you. I have 32 of you. I need all of you to sign in. Remember, as I said, this is what I copy. And every day I copy and paste for attendance. That's what I use as my attendance list. So let us all sign in. I hope you are okay. If you have any query, please raise it. I have, as I said, I have sent you the structures of these compounds. So make sure, and in fact, not only the structures, and I've actually sent you most of the things we are discussing. So organize those structures. As I say, they are not organized. They organize and organize all those structures as per the classification according to their structure. Remember, ours as PharmChem students, our most important classification is as per the structure. As per the structure. Any questions? So from next time, we look at the general SAR, but we have mentioned quite a lot of it. It is just now polishing and putting the general SAR in point form. And because there is a general SAR which must be obeyed, and then after that, we'll go for the specific, as we discuss every class, we go for the specific SAR, But there is a general SAL which I've already talked about. These drugs must have an anionic site. They must have 2 hydrophobic centers. What is the distance between the carboxylic acid and the first hydrophobic center? So these are the general SARs, but there will be those specific, which with the some of them will be a repetition of what we have done, but there will be unique ones associated with every class, which allows for salicylic acid to have a carboxylic acid directly attached, and also allows for ibuprofen to have an acetic acid, for ibuprofen to have an acetic acid, and for indomethacin, ibuprofen, sorry, to have a propionic acid, and for indomethacin to have acetic acid. So we look at the general and of course the specific for each group. But by now, please start mastering the classification. We did mention about 6 classes. Master them. What are the differences or differences between these compounds, and what are the similarities? What is the similarity between ibuprofen and indomethacin? What are the similarities and what are the differences? So I don't know whether you have finished signing in. So all of us, nobody is asking a question. Does that mean we are happy?
Good morning, Doctor.
Yes, morning.
So I'm having a bit of trouble following up as you are explaining.
Yeah.
And I was wondering if you could send us. Yes.
What is the problem?
So I'm having trouble, let's say, when taking down notes and listening, because now I have to concentrate on the still take down notes.
Yes.
So I was wondering if you could avail the notes, because I saw that you are not recording the sessions.
No, I don't record. But you see, even if I was start teaching in class,
yes,
you have to listen and put the notes, Manyange. Give me another good reason, not the fact that now you have advantage that there's a screen and there are points on the screen.
Yes, but you're explaining even things that are not even on the screen.
Yes, you see why I explained if there's a point.
Yes.
If there is a point, if I don't explain that point, you will be left hanging, isn't it?
Yes.
Yeah, I will see what I can. I don't, what I don't like about giving notes is that students are so fond of just cramming. And let me tell you, to come up with these notes, I spend a whole day or even weeks. You get my point?
Yes.
Manyange, like now, yeah?
Yes.
And just write medicinal chemistry, non-steroidal anti-inflammatories. People, it will give you a lot of notes, yeah?
Yeah, true.
Which are very similar perhaps to what I have given. Yeah. The only that, of course, mine, I refine them. Okay? Yes. But I will see you. Mumeuliza hizi notes sana. But the problem I have is that once you start getting notes, some of you don't even come. You come to class, you don't concentrate. That's what I mean. You see, Manyange, what I'm talking about, eh?
Yes.
After all, you have notes you can read and cram. Then you produce for me answers just crammed, eh? That's why you find me not giving you. And then again, there's a difference between, as far as I'm concerned, university, high school, primary. In university, we are training you also to be a researcher. You don't even have to, as long as you tell me, you people, you can't make notes. Manyange.
Yes.
Hello, Manyange. Umepotea?
Yes. No, mimi niko.
Umepotea?
No, actually, niko hapa.
Hello, Manyange.
Yes, I'm here.
I'm saying as a researcher and at your level, as long as I've guided you, like now I have sent you all the structures. When you look at the structures I've sent you, most of what I have here, yeah. Actually, the first structure is showing mechanism of action. The next one is showing the similarity between the arachidonic acid and so you see what the things I'm discussing.
Yes.
I've actually sent to you. I've sent you the structures of salicylic acid, sodium salicylate. First of all, go and look at them. I've sent you even the things we are going to discuss, metabolism. I've sent you quite a lot, yeah?
Yeah.
In terms of, you will not go looking for the structures of these drugs. And some of the metabolic processes I've also sent to you, yeah?
Yeah.
But I will still see. I will look up. I will see whether I will send it to you. I will see. I was also to send to you the one for prostaglandins, eh?
Yes.
But I think I'll send them at the end. Because if I send them now, you will not come to class.
It's okay.
Utakataa class, eh?
It's okay.
Wacha tusome kidogo.
Yeah.
That it's unfortunate that sometimes students don't want to come to class. And it's very important to be there. So wacha tusome kidogo, tukisoma kidogo. Then I will to send, yeah? Okay?
Yeah.
Because you guys have really appealed, and I'm thinking I'm getting a soft spot, although I never do it even for the other students. But I hope you have understood what we are doing. Have you, Manyange?
I have.
You have, but at least the first thing is to have an understanding, to understand the structures, to understand what we are talking about. Yeah. Once you understand, then now when you get the notes, you can fill in the gaps. If you don't understand, the notes will not mean anything. You get my point?
Yes.
If you don't understand, the notes will mean nothing, and that is why you have to cram them and reproduce my notes. And as I tell my students, you don't need to reproduce those notes at all. You can put those notes in your own language. You can put the answers in your own language, as long as you have understood. Like we are talking about the mechanism of action. You don't have to repeat what I have said. You just explain. These drugs are acidic in nature. Because they are acidic in the stomach, they will be ionized. The ionized molecule will better penetrate the membrane. You see what I mean? It's a matter of understanding. But sometimes when I give you notes, you feel like you need to reproduce what I have written in the notes. No. In fact, I feel very frustrated when you reproduce. So the issue is to understand. Yeah? Okay?
Okay.
And then also when we are writing point notes, as I explained, you need to learn how to write short form, shorthand. This shorthand, Manyange.
Yeah.
You just put the important points. Point. You leave in the evening, you sit with your shorthand notes, yeah, and now you complete them. I remember when I was also in college, you couldn't understand my notes. They used to have very many gaps in the middle, but I would leave gaps where I know, like the one, however, I leave the gap. And when I come back in the evening, I sit with my notes and I fill in all the gaps. Are we together?
Yes.
But as I've said, the appeal, I've heard you. I'll see what I can do. But first of all, look at the structures I've sent, yeah?
Okay.
All right?
Yeah.
All right. You're very welcome. And I'm happy at least present. I hope that is everybody. Any other person, anybody else with any comment here that we are still 31? Any other comment? Any other comment? Please feel free to comment. Any other comment? Any other comment? Are we good? Any other comment? So if that is the case, then where this Newton is writing something. Fine. We do not have any other comment. I think I can save these numbers. I can save those present. From Tonui. Now, all being the same and God being our keeper, we should meet on Wednesday. Kindly by Wednesday, look at those structures. Try to understand them. As I have said, not very hard. It's not very difficult. It's possible.